Okay, we move on to question 6. Tuberculosis is an infectious disease caused by mycobacteria. So again, topic 6. Most cases of TB are caused by infection with Mycobacterium tuberculosis, M. tuberculosis. The ribosomes of the bacteria are, okay, so dipped into topic 3 in the prokaryotes versus eukaryotes. The ribosomes of bacteria are smaller, so we know that. The larger than ribosomes, and so they're not larger. They are smaller than ribosomes in eukaryotes. So far, that's my best option. The same size as ribosomes in animal cells, so bacteria are prokaryotic. So they don't have the same size ribosomes, so that's wrong. The same sized ribosomes as plant cells, so plant cells are eukaryotic, so it's not that one. So I'm going to go with B. Okay. The ribosomes of bacteria are okay. Right. Okay. So the graphs show the number of cases of TB and the number of deaths from TB worldwide from 2000 to 2015. In 1993, the World Health Organization declared TB a global public health emergency. Since then, there has been a program to reduce the impact of this disease, analyze the data to deduce the effectiveness of this program. Analyze the data to deduce the effectiveness of the program. Okay, so I must make sure that I do those things. All right, so let's see. All cases stay the same, pretty much. New cases rise. Okay, so we've got all cases, we've got new cases going up, we've got new cases staying the same, and basically we've got TB deaths decreasing. Okay, so that's level, that's rising, and that's going down. Okay, so analyze the data to deduce the effectiveness of the program. So number of cases in millions. Analyze it to deduce the effectiveness of the program based on the data. So shall I go with no change in all cases? Okay. There is an increase in new cases. There's an increase in new cases. But there's a decline in the deaths. So deaths due to TB has declined. Deduce the effectiveness. I wonder if they want two answers. So the number of new cases has been rising, but the number of deaths are falling. So what does that mean? Increase in new cases, but deaths due to TB has declined. Reduce the impact. So that's kind of vague as well. Reducing the impact. So is it effective? No change in all cases. Increase in new cases, but deaths due to TB has declined. No change in all cases. Man. the worrying thing is, I think I've seen this question before, but it still got me. I think I'm overthinking it. Analyze the data to deduce the effectiveness of the program. So even though there's no change in all cases, there's an increase in new cases, but the deaths due to TB has declined. Alright, so increase in new cases, but deaths due to TB has declined. Deduce the effectiveness of this program. I feel it's quite subjective though. Depends what the impact was supposed to be for. Okay, no change in all cases, increase in new cases, but deaths due to TB has declined, so program is effective. So we've got more, maybe deduce the effectiveness of this program. So we don't know what they did. So if more people have TB, but fewer are dying, that means treatments for TB, treatments for TB must have improved. Treatments for TB must have improved. So the people that have it, yeah, okay. But the thing is, the number of new cases have increased. Number of cases in millions. All cases. All cases. I wonder if there's something there, because I'm comparing this one to this one. But I wonder whether the all cases is telling us something. So if the all cases is staying level, but the new cases is rising, because all cases means existing people that already have it, and new cases, so all cases overall has declined a little bit. Slight decrease in all cases, increase in new cases, but deaths due to TB has declined. So program is effective because treatments for TB must have improved. Okay, I do not like my answer there, I've got to say. Right, individuals with M. tuberculosis can be treated with antibiotics. 4 of the antibiotics used to treat TB are shown in the table. Okay. In one clinical trial lasting 6 months, the effect of treating TB with these antibiotics was investigated. All patients were treated with all 4 antibiotics for 2 months. Then they were treated with different pairs of antibiotics for a further 4 months. All patients were free of any signs of active TB at the end of the clinical trial. Okay. So that might be significant. The design of the trial and the percentage of these patients with TB 3 years after the trial ended are shown in the diagram. Alright, so for 2 months, all patients were free of any signs of active TB at the end of the clinical trial. Percentage of patients with active TB after 3 years. Okay, right. So basically none of them had active TB at the end, and then even after the trial then we have 9, 32, 9, 11, 32, and 30. Okay. Analyze the data to comment on the effectiveness of these antibiotics for the treatment of TB. Okay, so, all right. So what's the overall trend, right? So when we've got data, the overall trend is that actually all of them are to some extent effective at treating or all of them are to some extent effective in treating TB. Okay, so, but what's the evidence for that? So all are effective. Well, I've just gone straight into it, isn't it? So what I would suggest is, because what is this? This is a 6 marker. So we're going to have to split this up. So how I would go about it, because with these kind of questions, there's the data. There's judgments based on the data. Okay, and there's linkages. So like associating what's the information that's been given to you with stuff that you know. So we must try and do these things. So the first thing we're going to do is make some judgments based on the data, and then we're going to use the table up here, because the table here includes some information that we could connect to our knowledge about the different types of antibiotic and how they might work. Yep. Okay, so that's basically how we're going to break it up. So I will begin there. All are effective as relatively low percentages of act. So as most patients didn't have active TB after 3 years. So that's my first point. Okay, so that's the overall thing. Now let's look a bit more detailed. Were some combinations better than others? So if we look here, combinations group 3 and 4 had more patients with active TB compared to 1 and 2. Yeah, so that will be my next point. So we're still making judgments based on the data. Groups 1 and 2. So rifampicin and pyrazinamide. So let's just call it groups 1 and 2. Actually, we should use the names of the antibiotics. Rifampicin, so actually groups 1 and 2 were more effective. Let's just, groups 1 and 2 were had lower percentage of active TB than 3 and 4. Okay, all right. Anything else? After 3 years. Okay, so that's that. And right, and then now we could go into that, and now let's link to this table and see. So rifampicin and pyrazinamide, rifampicin inhibits bacterial RNA polymerase. Okay. So that would stop protein synthesis, so that might be bacteriostatic. Isoniazid inhibits synthesis of fatty acid needed to make cell walls, so that would be bactericidal. Streptomycin binds to bacterial ribosomes to prevent binding of tRNA, so that might be bacteristatic as well. Not yet known, but not the same mechanisms as the other three. Okay. So I guess it's different, right? So rifampicin and pyrazinamide, if we put them together, they've got different, right? So they have a different mechanism of how they work. Isoniazid and rifampicin, right? One was bactericidal, one was bacteriostatic, so again, they are different. Isoniazid and pyrazinamide, we don't know, but they might be the same. Okay, unknown. Oops, that's unknown. And isoniazid is by itself, so yeah. Okay, right. So fine, what we could add is, so we're trying to make some linkages now. What we could do is say, right, perhaps rifampicin, so groups 1 and 2, the antibiotic combinations, just to save me time, antibiotic combinations used in groups 1 and 2 have different mechanisms, and so may be more effective. Okay, but yeah, I do need to walk the examiners through my thought process. I can't just leave it on the table there, right? So e.g. rifampicin is could be rifampicin could be bacteriostatic, right? And pyrazinamide was not known, so now I'm not going to use that as an example, but rifampicin and isoniazid is bactericidal. Isoniazid is bactericidal. Okay. Yep. All right. What else do we have? Okay. I mean, I think we should finish off by saying, wait, is that enough though? All are effective. Most patients didn't have active TB after 3 years. Groups 1 and 2 had a lower percentage of active TB, and antibiotic combinations used in 1 and 2 have different mechanisms, may be more effective. Rifampicin bacteriostatic, isoniazid bactericidal. Right, I think we'll go into the limitations now of this. So, all are effective. I mean, maybe should I go a bit more bacteriostatic? Why am I saying that rifampicin is bacteriostatic? Probably should explain myself a little bit there. Bacteriostatic because inhibits protein synthesis, right? And we're saying isoniazid is bactericidal because disrupts cell wall, right? Can cause cell lysis. Okay, and then I would finish by just critiquing, or critiquing the data itself. So what are the limitations of the data, basically? We don't know how many people were in the study. We don't know if the sample size was large enough. Okay, what else? We may not know. We don't know if they had active TB after the 3 years. We don't know we don't know percentages with active TB after 3 years. Beyond 3 years. We don't know percentages with active TB just to make myself clear, e.g. 5 years, 7 years. Okay, right, and that's question 6. Am I missing anything important here? All patients were free of any signs of active TB at the end of the clinical trial. The design of the trial. Okay, we don't know if the sample size was large enough. Maybe I might say how many in each group. How many in each group? Okay. Yeah, I'm not really super sure about that one, but had a method, followed a plan.